Hello, just wanted to go through the Canadian Neurological Scale. I've posted this PowerPoint on its own. If you don't want to follow along and just go through it yourself, it is in the folder. What I do recommend is that you print off the Canadian Neurological Scale, the observational record that's posted in our Blackboard, and follow along with it while you listen to the PowerPoint. Okay. So the Canadian Neurological Scale, what it is a tool that's been recommended by the Heart and Stroke Foundation of Ontario. It's considered a best practice guideline for assessment of acute stroke patients. Okay, and it really is measuring the degree of impairment that they might be experiencing. The Glasgow Coma Scale is another assessment scale that you've probably heard of before. Okay, and the Glasgow Coma Scale is different in that it's looking at neurological system dysfunction resulting in coma. Okay, so what's different is really the CNS is really looking at a complementary scale to assess that conscious or aphasic patient. So when we look at the scale and we look at scores, a score of 11 or better tend to be associated with more favorable outcomes. Okay. And lower scales are going to be associated with things like greater predictor of death, morbidity, and more limited recovery to resume normal activities of daily living. So what you will find in terms of using it is that most agencies will have a policy for how often they want it done. They will also likely have a template that they use within their agency. So you'll need to look for this template within your agencies. And what you will notice is it might not be called the Canadian Neurological Scale, but that will be integrated within the template that they use. So when we look at the scale, it's an 11.5 point scale that has 3 components. It has a section A, A1, and A2. Section A, mentation, looks at level of consciousness, orientation, and speech ability. And so you're going to complete section A with all. Okay. Then what you'll look at is from there, either you'll complete section A1 or A2. And so section A1 will be selected to look at motor function in someone with no comprehension deficit, meaning that that patient can obey and respond to sort of commands when you ask them to do things, versus section A2 would assess motor function in someone who does have comprehension deficit, someone who has difficulty or cannot understand and obey commands. So as you're implementing this scale, okay, getting started is the first thing that you're really going to look to do is to assess pupils. You're looking at those for the size, reactivity to light. You're also going to do your set of vital signs. Now, anything that's changes to pupils or to vital signs that would be concerning to you would warrant identifying that with a physician. Okay. If not, you can continue on, and then you're going to begin to assess level of consciousness. So if they're alert or drowsy, then you could use the CNS. That would identify that yes, this patient is a candidate to use the scale. If they are comatose or stuporous, then we would look to the Glasgow Coma Scale instead. Okay. And then from there, you're really assessing orientation, speech, and motor functioning. What you'll see here is just some definition of some terms. I think you need to just read and memorize some of these so that you can identify them within your clients. If we progress then to section A, mentation, what I'm talking about here is that we're doing this with all of our clients. Okay, so here we're looking first at level of consciousness. If they're alert or drowsy, they would get a score accordingly. So the alert person would score a 3.0. While the drowsy person would score a 1.5. Okay. In terms of looking at orientation, you can ask them where you are and what month and year it is. Okay. If your patient cannot speak, it is allowed that they can write the answer to the questions down for you. Okay. If the patient cannot state both place and time, okay, they would then get a score of 0. So then the next part that we're going to assess is speech. Okay, and here we're assessing for any receptive deficit. Okay, there's 2 categories when assessing this. We're looking at receptive and expressive. Okay, so it's receptive is this understanding of being able to ask them to do something and they can understand what you're saying. So you would ask them, you would give them the 3 commands, and they would need to follow and do what you're asking them. So, for example, asking them to close their eyes or point to the ceiling. Okay. If the patient is not able to complete all 3, they would score and I'd be identified as having a receptive deficit, and they would score a 0. If they score a 0, you do not assess expressive deficit, and you would go right to section A2, which is motor response for the receptive deficit present. Okay. If there is no receptive deficit, then you would assess for an expressive deficit. Okay, so if you're going to then, if there was no receptive deficit, then you want to assess for the expressive deficit, okay? And this is the idea that they can understand but just can't communicate it, okay? And so you're going to ask them to name 3 objects and the use of each. So for example, what is a key and what is it used for? A pencil or a watch, same thing, okay? If they cannot name all 3 objects and use each, they would score an expressive deficit and they would get a 0.5. Because here we are assessing speech, a written response is not accepted because we're really looking at assessing speech and not comprehension. If you find that during your assessment they're able to answer you, but they do have slurred speech, you would just put an SL beside the score. Okay? If you find that they have no expressive deficit, they would score normal speech and they would get a 1.0. If your patient now at this point has an expressive deficit or normal speech, then you would go to section A1 of the motor response. So if you go to A1, it means that they have no receptive deficit. Okay. So A1 for motor response and no receptive deficit. Here, we're really looking at the face first. We're asking the patient to smile, show their teeth and their gums, testing some of those cranial nerves, okay? Looking for asymmetry of the mouth and the face, and looking for any sort of weakness, okay? If we note weakness, they would get a score of 0. If there's no weakness, they would get a score of 0.5. And as we're doing our assessment, we would note the side exhibiting the worst deficit using either right or left side. Okay. Next, we would assess the proximal arms. Okay. And so we're submitting both arms to the same test, and again, looking at whether the right or left side exhibits a worse deficit. Okay, so with the arms, if the patient's sitting, you have them lift them to shoulder level of 90 degrees and apply resistance just above that elbow bilaterally, and see if they can push back against that resistance. And again, if they're lying in bed, you're going to have them elevate the arms to 90 degrees and apply resistance again bilaterally. Okay, so really here we're looking for, can they resist against that you're pressing down. So scoring for that, if there is no weakness at all, they would get a 1.5. If it's mild, okay, they can move it to 90 degrees, but they're not able to oppose the pressure that you're using, they would score a 1.0. And if they're not even able to move the arm to 90 degrees, they would get a 0.5. And if they can't have any movement at all, they would get a 0. Okay. Then we would assess the distal arms, okay? So again, submitting both arms to the same test. Any worse deficit on the right or left side would be what we would be doing here. Okay. So with the arms outstretched and the wrist cocked back in a dorsiflexion of the hands, okay, you're going to support the patient's arms while you put pressure between the wrist and the knuckles and pushing back on that, and can they push back at you? Okay. So again, for this one, same scoring as above in terms of weakness. Okay. Absence of movement would be on a scale of 0 to no weakness at all at 1.5. And if they're in the middle, you would score them accordingly. We then move to the legs. Okay, so again, submitting both the legs to the same testing, recording the side that exhibits worse deficit. Okay. Here we're bringing the thighs towards the body, keeping the knees flexed at 90 degrees, pushing down at one on each of the thigh, one at a time. Okay, and very similar scoring to the arms. And then again with the feet. Okay, so I'll let you read through that one, and very, very similar scoring to what we've seen in the last few ones. So if you did not complete A1 because they do have a receptive deficit, you would then complete section A2. Okay. So this is really looking at the motor response for the client with receptive speech deficit. Okay, and so this is going to be a little bit more challenging. You can have the patient try and mimic your own grin or show your teeth. Okay, hopefully you can show that to them and they might be able to show it back to you. Okay, so here again, that's what you're looking for. You're looking for noting any asymmetry of the mouth and the face. Okay, and if the patient's unable to cooperate, just observe. You can try observing their facial response when you apply really light pressure to the sternum area. Okay. So again, scores for the face really would be symmetrical or asymmetrical in terms of 0 and 0.5 scoring. For testing the arms for this client, again, you're demonstrating it and seeing if you can get the client to do and mimic what you're doing. If they're unable to cooperate, you can apply pressure to the fingernail bed, okay, bilaterally, and compare the response that you get. Okay. So again, you need to do it to both limbs. You need to note the deficit in right versus left, okay? And if it's equal motor response, it would be 1.5 versus unequal would be 0. When we look at legs, again, if the patient's unable to cooperate, apply toenail bed pressure bilaterally and then again compare that response. Looking again on the left and the right side, and the scores are 1.5 or 0 if they're unequal. Okay. Do they respond to that pressure? If you can get them to lift the leg by mimicking and trying to show them what to do, then that's really where you would want to start. So in terms of scoring for the CNS, okay, scoring for section A, you're going to do that for all patients, like we talked about. And then you're going to score your sections, either you did A1 or you did A2, depending on your client. You would never, ever do both sections A1 and A2 because that would give you an unreliable score. So you're either going to add section A and A1 together, or you're either going to add section A and A2 together. The maximum score that a client can score is an 11.5. Okay. If there's any move of more than 1 point in the scale, that would be significant and you would want to notify a physician. And again, like I said, if there's changes to vital signs or changes to the reactivity of the pupils, again, you want to be notifying the physician. And that's a little bit about the CNS.